Imagine this. You're sitting in your doctor's office. The nurse smiles, just a quick checkup. A blood draw. Maybe an ultrasound. Perhaps a scan, just to be safe. It sounds harmless, even reassuring. After all, isn't early detection the golden rule of modern medicine? But here's what almost no one tells you. After a certain age, some of these so-called routine tests can do more harm than good. They can trigger false alarms, unnecessary treatments, anxiety, and complications that affect not just your body, but your quality of life. What kept you healthy at 50 may quietly undermine your health at 75. In this video, we'll uncover 5 common medical tests older adults should think twice about, and then reveal the handful of screenings most experts agree are genuinely worth your time, trust, and energy. By the end, you'll know which to question, which to keep, and how to make these choices with confidence, wherever you live. Speaking of which, I'd love to know where you're watching from. Share your city in the comments. Our audience includes viewers from the US, the UK, Germany, and far beyond, and it's always inspiring to see this community come together. Stay with me, because what you're about to hear could spare you unnecessary worry, and might even save your life. Test 1. Routine CT and MRI. CT, computed tomography, and MRI, magnetic resonance imaging, have revolutionized modern medicine. They can reveal structures inside the body with extraordinary clarity, guiding diagnoses and treatments that save lives. In emergencies and for specific, well-justified medical questions, these technologies are invaluable. But when used routinely in older adults, without a clear reason, these scans can lead to harm that far outweighs their benefit. Let's start with CT scans. A CT uses multiple X-ray images to create detailed cross-sectional pictures of the body. The problem is that this precision comes at a cost: radiation exposure. One CT scan can expose a patient to as much radiation as 100 to 200 standard chest X-rays. For older adults, whose cells may already be more vulnerable to DNA damage, this added radiation can increase the risk of tissue injury or even late-onset cancers. While the risk from a single scan is small, repeated just to be safe, imaging over several years can cause cumulative harm, especially when the scans are not medically necessary. The more immediate problem, however, isn't radiation, it's what these scans find. When a CT scan is done without a specific medical indication, it often reveals incidental findings: harmless cysts, benign nodules, minor scarring from old infections, or age-related changes in bones and organs. These findings are normal signs of aging, but the skin doesn't label them as harmless, it simply flags them as abnormal. And that's where the cascade begins. Once an abnormality is detected, physicians feel pressured to investigate further, ordering additional imaging, biopsies, or even surgery. Each step carries its own risks: bleeding, infection, anesthesia complications, and just as damaging, the anxiety of waiting for test results. What started as a precautionary scan can end with a frail patient undergoing invasive procedures for something that would never have caused illness. MRI scans, on the other hand, don't involve radiation. They use strong magnetic fields and radio waves to produce images. This makes them safer in terms of long-term radiation risk, but MRIs have their own set of problems when used indiscriminately. For one, they often require gadolinium-based contrast agents to enhance image clarity. In older adults, especially those with reduced kidney function, these contrast agents can accumulate in the body and, in rare cases, cause nephrogenic systemic fibrosis, a serious and potentially debilitating condition. Even in patients with normal kidney function, residual gadolinium can remain in certain brain regions for years, with unknown long-term consequences. Like CT scans, MRIs are also prone to detecting incidental findings. A brain MRI in a healthy older adult might show tiny white spots, often just age-related changes in small blood vessels, or a small benign tumor like a meningioma. These findings rarely cause harm, but once they're documented, the patient may be subjected to years of follow-up scans, unnecessary interventions, and constant worry. The evidence supports caution. A study published in JAMA Internal Medicine found that in people over 70, more than 30% of advanced imaging tests led to follow-up procedures for incidental findings that ultimately proved harmless. These extra procedures were not without cost, both financially and in terms of physical and emotional strain. So when is CT or MRI appropriate for older adults? The answer is simple: when there's a clear, evidence-based reason to look. For example, a CT scan might be warranted in the setting of acute trauma, suspected stroke, or unexplained internal bleeding. An MRI might be justified for sudden neurological symptoms, severe unexplained headaches, or a suspected spinal cord problem. In these scenarios, the benefits of rapid, accurate diagnosis far outweigh the risks. Test 2. Annual full blood panels, false alarms and overmedication. For many older adults, the annual blood test has become a deeply ingrained ritual, part reassurance, part routine. You make an appointment, the nurse draws a few vials, and a week later you receive a report full of numbers and abbreviations. It feels proactive, responsible, and safe. But here's the uncomfortable truth. For healthy people over 70, routine full blood panels often provide little genuine benefit and can trigger a cascade of unnecessary follow-ups, medications, and side effects that do more harm than good. To understand why, let's start with what a full blood panel actually measures. Most primary care offices order a complete blood count, CBC, and a basic or comprehensive metabolic panel, BMP or CMP. These tests check things like red and white blood cell counts, hemoglobin, electrolytes, kidney and liver function, and blood sugar. Sometimes cholesterol levels, thyroid hormones, or vitamin levels are added. While this seems comprehensive, the reality is that these values fluctuate naturally from day to day, and even hour to hour, based on stress, hydration, recent meals, sleep quality, or mild infections. For younger adults, small fluctuations are often ignored. But in older adults, where reference ranges are still based on younger populations, perfectly normal age-related changes can be misinterpreted as abnormal. A slightly low sodium level, a mildly elevated liver enzyme, or a borderline thyroid hormone result can set off alarm bells, leading to repeat testing, referrals to specialists, and sometimes medications that are not truly necessary. This is how the cycle begins. Incidental finding. A number is slightly outside the standard range. Follow-up testing. More blood draws, sometimes imaging, to find the cause. Medications start. A drug prescribed to correct the abnormal value. Side effects, dizziness, electrolyte shifts, digestive issues, or interactions with other medications. New problems, prompting more tests, and sometimes even hospital visits. This cascade is especially dangerous in older adults, who are often already taking multiple prescriptions. Adding unnecessary drugs increases the risk of polypharmacy, the simultaneous use of many medications, which raises the likelihood of drug interactions, confusion, falls, kidney strain, and other complications. Scientific evidence backs up these concerns. A study from the University of Oxford found that in people over 70, routine annual blood panels led to unnecessary treatments in over 40% of cases, most of which offered no measurable health benefit. Many of the abnormalities detected were benign, age-related variations that would not have caused symptoms or required intervention. This doesn't mean blood tests have no place after 70. They can be vital when used targetedly. The difference is purpose. Blood work should be ordered to answer a specific clinical question. Unexplained fatigue, check for anemia. Sudden weight loss, check thyroid and inflammation markers. Bone pain, check calcium and vitamin D. Or swelling, check kidney and liver function. In these situations, the results guide real medical decisions that can improve outcomes. The bottom line, in healthy older adults, the annual full blood panel can be more ritual than medical necessity. Without a clear reason, it risks turning small, harmless deviations into full-blown medical issues, complete with unnecessary medications and side effects. The smarter strategy is to reserve blood testing for situations where the results will directly influence treatment decisions. Test 3. Colonoscopy. For decades, colonoscopy has been held up as the gold standard for colorectal cancer screening, and for adults between the ages of 50 and 65, that reputation is well earned. Detecting and removing polyps before they become cancerous can dramatically reduce mortality from this disease. But after the age of 75, the calculus changes. The potential harms of colonoscopy begin to outweigh its benefits for many older adults, and continuing with routine screening can lead to complications that are far more dangerous than the condition it's meant to prevent. The first thing to understand is that colorectal cancer behaves differently in older age. In younger adults, certain types of polyps and tumors can grow quickly, sometimes advancing from precancer to cancer in just a few years. In people over 75, however, most colorectal cancers develop much more slowly, often so slowly that they would never cause symptoms or shorten life expectancy within a person's remaining years. This means that detecting and removing a slow-growing polyp at 78 may not extend life, but the procedure itself can carry very real risks. A colonoscopy is not a benign test. The preparation alone, usually a powerful laxative solution taken the day before, can cause dehydration, electrolyte imbalances, and weakness, which are more dangerous in older adults. For people with heart problems, kidney issues, or other chronic conditions, these shifts in fluid and electrolyte balance can trigger serious complications, such as arrhythmias or acute kidney injury. Then there's the sedation or anesthesia used during the procedure. While often considered routine, sedation in older adults is riskier because of age-related changes in how the body processes medications. Older brains are more susceptible to post-anesthesia confusion, delirium, or even long-term cognitive decline, especially in those who already have mild memory problems. Cardiovascular complications are also more common, including drops in blood pressure or irregular heart rhythms during or after the procedure. The procedure itself carries inherent mechanical risks. The colonoscope, a flexible tube with a camera, is inserted through the rectum and advanced through the entire colon. In experienced hands, this is generally safe, but in older adults with more fragile tissue, the chance of causing a perforation, a tear in the wall of the colon, increases significantly. A perforation is a medical emergency that almost always requires surgery and carries a high risk of infection and even death in frail patients. Bleeding is another concern. Removing polyps, especially larger ones, can cause significant bleeding during or after the procedure. While this is usually manageable in younger, otherwise healthy individuals, older patients, especially those taking blood thinners for heart disease or stroke prevention, can face severe bleeding that requires hospitalization, blood transfusions, or additional procedures. The numbers paint a clear picture. Research from the Harvard Medical School found that adults over 75 have up to a 7-fold higher risk of serious complications from colonoscopy compared to younger patients. These complications include perforations, severe bleeding, infections, and cardiopulmonary events related to sedation. At the same time, the likelihood of detecting a truly aggressive cancer that would impact life expectancy is relatively low in this age group. So when might colonoscopy still make sense after 75? The key is individual risk assessment. For someone in excellent health with no major comorbidities, who has never been screened before, or who has a strong family history of colorectal cancer or known high-risk genetic mutations, the potential benefits may still outweigh the risks, especially if the person is expected to live another 10 years or more. But for the majority of older adults who have already had negative screenings in the past, the benefit of continuing routine colonoscopies is minimal. Fortunately, there are safer alternatives that can still offer meaningful cancer surveillance without the same procedural risks. The fecal immunochemical test, FIT, is a non-invasive stool test that detects hidden blood, which can be an early sign of colorectal cancer. While it's not as comprehensive as a colonoscopy, it can be done annually at home, requires no bowel preparation, and poses no risk of sedation or tissue injury. If the FIT test shows abnormal results, a colonoscopy can then be considered, but only as a targeted diagnostic step rather than a blanket screening tool. Test 4, mammography, when screening becomes overtreatment. For decades, women have been told that regular mammograms save lives, and in certain age groups, that's true. Between the ages of 50 and 69, screening can detect aggressive breast cancers early, when treatment has the best chance of success. But past the age of 70, the balance between benefit and harm begins to shift, and often in ways that older women are rarely told about. To understand why, you need to know how breast cancer behaves later in life. In younger women, malignant tumors are more likely to be fast-growing and aggressive, spreading quickly if left untreated. In older women, however, breast cancers are often biologically different. They tend to grow slowly, remain localized for years, and crucially, may never cause symptoms or threaten life expectancy. Detecting these tumors early does not necessarily improve outcomes, yet the act of detection almost always sets a chain of events in motion. Here's how it usually plays out. A screening mammogram picks up an abnormality. This could be a small shadow, a calcification, or a slight tissue change. The radiologist cannot dismiss it outright, so more imaging is ordered. If the spot is still considered suspicious, a biopsy follows. That's an invasive procedure, often requiring local anesthesia, sometimes sedation. The tissue is analyzed, and in many cases the result shows a low-grade, slow-growing tumor or even a benign lesion. But the psychological and physical toll has already begun. There's the anxiety during the waiting period, the discomfort or pain from the biopsy, and the lingering fear even if the result is not dangerous. And if the pathology confirms cancer, even a slow-growing, non-aggressive type, most women are steered towards surgery, radiation, or hormone therapy. For a 75-year-old, this treatment pathway can be more harmful than the tumor itself. Surgery carries anesthesia risks, slower wound healing, and higher infection rates in older patients. Radiation can cause skin damage, fatigue, and in some cases, cardiovascular complications. Hormone therapies can trigger joint pain, bone thinning, and increased fracture risk. All for a cancer that might never have caused illness in that person's natural lifespan. The data is sobering. A large U.S. study found that women over 70 who underwent routine mammography did not have significantly lower breast cancer mortality than those who skipped the screening. Yet they experienced substantially higher rates of unnecessary biopsies, surgeries, and treatment-related side effects. In other words, the benefit plateaued, but the harms accumulated. And then there's radiation exposure. A single mammogram involves a low dose, but over years of repeated screening, the cumulative exposure adds up. While the absolute risk from mammography radiation is small, it's not zero, especially for older breast tissue, which can be more sensitive to DNA damage from ionizing radiation. For some women, the theoretical risk of inducing harm begins to outweigh the actual benefit of detecting a tumor that may never progress. The problem is that screening guidelines are often slow to adapt to new evidence, and cultural messaging around mammography is deeply ingrained. Many women fear that skipping a mammogram will be viewed as reckless or irresponsible, even when the science suggests it's a reasonable choice. This social pressure is amplified by decades of public health campaigns equating early detection with saving lives, without emphasizing the nuances of age, tumor biology, and individual health status. So, what's the practical takeaway? First, have an honest conversation with your physician about your individual risk profile. Ask about the specific benefits and potential harms of continued mammography at your age, given your health status and life expectancy. Second, if screening is chosen, understand that not every finding requires aggressive treatment. Watchful waiting or active surveillance can be a safe option for slow-growing tumors. Third, know that declining a screening test when the evidence suggests limited benefit is not neglect. It's informed, self-protective decision-making. Medicine is most powerful when it's personal. Past 70, the goal is not simply to detect disease at all costs, but to protect quality of life, preserve independence, and avoid interventions that may cause more harm than good. Mammography can be life-saving in the right context, but in the wrong one, it can quietly turn healthy women into patients with all the risks that follow. Test 5, PSA blood test. For many men over 60, the PSA blood test has become as routine as a yearly physical. The test measures the level of prostate-specific antigen, PSA, in the blood, a protein produced by the prostate gland. Elevated PSA levels can indicate the presence of prostate cancer, which is why for years it was promoted as a simple, life-saving screening tool. But the reality, especially for men over 70, is far more complicated. In fact, widespread PSA testing in older men is one of the most debated topics in modern medicine. The first problem is that PSA is not specific to cancer. Levels can rise for many benign reasons: an enlarged prostate, benign prostatic hyperplasia, inflammation, prostatitis, recent sexual activity, even something as simple as riding a bicycle. These non-cancer causes are common in older men, meaning false alarms are frequent. A slightly elevated PSA can trigger a cascade of follow-up tests, most notably a prostate biopsy. A biopsy involves inserting needles through the rectal wall to remove tissue samples from the prostate. While usually done under local anesthesia, it's far from risk-free. Potential complications include bleeding, infection, urinary problems, and long-term pelvic discomfort. For some men, these side effects last weeks or months. Even more concerning, studies show that a large percentage of prostate cancers detected this way in older men are slow-growing tumors that would never have caused symptoms or threatened life expectancy. Here's the crux of the dilemma. Once cancer is found, even a harmless one, most patients and doctors feel compelled to treat it. And that treatment can carry life-altering consequences. Surgery to remove the prostate, prostatectomy, and radiation therapy both come with significant risks. Urinary incontinence, erectile dysfunction, bowel problems, chronic pain, and fatigue. For a man in his 70s, the potential harm from these interventions can easily outweigh the benefits, particularly when the cancer might never have progressed. The statistics are telling. According to the U.S. Preventive Services Task Force, USPSTF, for every 1,000 men screened with PSA over the age of 70, only a small fraction will avoid death from prostate cancer, yet dozens will experience serious complications from biopsy or treatment. In fact, 7 out of 10 prostate cancers detected in older men are classified as low risk or indolent, meaning they grow so slowly that the patient is far more likely to die with the cancer than from it. So why is PSA testing still so common? Partly because it's quick, inexpensive, and deeply embedded in medical culture. Many men request it out of habit, believing more information is always better. And many physicians offer it without fully explaining the limitations and risks, worried that skipping the test might miss a rare aggressive cancer. But guidelines have shifted. The USPSTF and many major medical organizations now recommend against routine PSA screening in men over 70, unless there are exceptional risk factors, such as a strong family history of early, aggressive prostate cancer, or known high-risk genetic mutations like BRCA2. For men in their 70s who still want to evaluate prostate health, there are more nuanced options than a single PSA reading. Free-to-total PSA ratio testing can help distinguish between cancerous and non-cancerous causes of elevated PSA. Multiparametric MRI can visualize suspicious areas before deciding on biopsy, reducing unnecessary invasive procedures. Some specialists also use advanced biomarker tests that improve accuracy and reduce false positives. The practical approach is this. If you are over 70 and asymptomatic, no urinary difficulties, no blood in the urine, no unexplained pelvic pain, the potential benefits of a PSA test are minimal. If you do have symptoms, the test can be part of a targeted diagnostic workup, but it should never be the sole decision maker for invasive procedures. And if a slow-growing tumor is discovered, active surveillance, regular monitoring without immediate treatment, can be a safe, quality-preserving option. Recommended screenings 1. Blood pressure and atrial fibrillation monitoring. Not every test loses its value after 70. In fact, some become more important than ever, because they can detect conditions that are both silent and dangerous, yet highly treatable when caught early. At the top of that list is regular monitoring for high blood pressure, hypertension, and atrial fibrillation, AFib, a common heart rhythm disorder. Together, these two conditions account for a significant share of strokes, heart failure cases, and premature deaths in older adults, and the right screening can prevent many of them. Let's start with blood pressure. Hypertension is called the silent killer for a reason. It often has no symptoms until it causes serious damage. In people over 70, uncontrolled blood pressure is a leading risk factor for stroke, heart attack, kidney failure, and vascular dementia. Unlike some of the diseases we've discussed earlier, high blood pressure can progress quickly, and lowering it, even modestly, can substantially reduce the risk of catastrophic events. The beauty of blood pressure screening is its simplicity and safety. It can be done at a doctor's office, a pharmacy, or at home with a validated cuff. There's no radiation, no invasive procedure, and no major downside to regular checks. The key is consistency. Blood pressure should be measured at least once every few months, and more often for those with a history of high readings or cardiovascular disease. Home monitoring is especially valuable because it can detect patterns that a single office visit might miss, such as morning surges or white coat hypertension, where readings are elevated only in clinical settings. Then there's atrial fibrillation, the most common arrhythmia in older adults. AFib causes the heart's upper chambers to beat irregularly and ineffectively, allowing blood to pool and potentially form clots. If one of these clots travels to the brain, it can cause a stroke, often a severe one with long-term disability. The risk of AFib rises sharply with age, and many cases are asymptomatic. Some people feel palpitations or shortness of breath, but others have no warning until a stroke occurs. Screening for AFib can be as straightforward as a doctor feeling your pulse during a routine visit, but technology now offers better tools. A 12-lead ECG is the gold standard, but portable devices, such as finger touch or smartwatch ECG monitors, can also detect irregular rhythms with impressive accuracy. Periodic screening is especially important for those with high blood pressure, diabetes, heart disease, or a prior stroke. The benefit of detecting AFib is immediate and profound. Once diagnosed, doctors can prescribe anticoagulants, blood thinners, that dramatically reduce the risk of stroke by as much as 60 to 70% in eligible patients. For high blood pressure, effective treatment, whether through lifestyle changes, medication, or both, can cut stroke risk nearly in half and prevent heart failure. Unlike the overused tests we've discussed earlier, blood pressure and AFib screening meet every standard of good preventive care. They detect common, dangerous conditions. They can be done quickly, safely, and inexpensively. Early intervention significantly reduces both disability and death. The practical approach is this: have your blood pressure checked regularly and learn how to check your own at home. Ask your healthcare provider to check your heart rhythm at each visit, and consider periodic ECGs or wearable monitoring if you're in a higher risk group. These screenings are not about over-medicalizing aging. They're about protecting independence and quality of life. A stroke can take away mobility, speech, and the ability to live independently in a matter of minutes. Regular monitoring is one of the simplest, most effective ways to keep that from happening. Recommended screenings 2. Bone density, DEXA, scans for fracture prevention. Among adults over 70, one of the most life-altering events isn't a heart attack or a stroke. It's a fracture, especially of the hip or spine. These injuries can trigger a rapid decline in independence, mobility, and overall health. In fact, the one-year mortality rate after a hip fracture in older adults can be as high as 20 to 30%, not because of the fracture itself, but because of complications like infections, blood clots, and loss of physical function. This is why targeted bone density screening, using a DEXA scan, dual energy X-ray absorptiometry, remains one of the most valuable and underused tools for people in their 70s and beyond. Why bone density matters after 70. Bones naturally lose density with age. For women, this decline accelerates after menopause due to a drop in estrogen levels. For men, bone loss is slower but still significant after 70. Reduced bone density leads to osteoporosis, a condition where bones become fragile and more likely to break even with minimal trauma, such as a fall from standing height or, in advanced cases, a strong cough or sneeze. Osteoporosis is often called a silent disease because there are no symptoms until a fracture occurs. By then, the damage is done. A vertebral compression fracture can cause chronic pain, reduced lung capacity, and posture changes that impair balance. A hip fracture often requires surgery, prolonged rehabilitation, and can permanently limit mobility. That's why prevention is the only real cure, and prevention starts with knowing your bone density. Why timing and targeting matter. For most healthy adults, a baseline DEXA scan is recommended at age 65 for women and 70 for men. After that, the frequency depends on your results. Normal bone density, repeat every 5 to 10 years. Osteopenia, mild bone loss, repeat every 2 to 5 years. Osteoporosis, repeat every 1 to 2 years to monitor treatment effectiveness. Importantly, not everyone needs repeat scans on a fixed schedule. If your bone density is strong and you have no risk factors, there's no need for annual testing. On the other hand, if you've had fractures, take medications that weaken bones like long-term corticosteroids, or have conditions that affect calcium absorption, more frequent checks are warranted. Risk factors that demand screening. Previous fracture after age 50. Family history of osteoporosis or hip fracture. Long-term use of steroids or certain cancer treatments. Low body weight or significant unintentional weight loss. Smoking or excessive alcohol use. Conditions like rheumatoid arthritis, celiac disease, or chronic kidney disease. Recommended screenings 3. Vision and hearing assessments. Visual changes are common with age, but they don't always happen gradually enough for people to notice. Cataracts, glaucoma, macular degeneration, and diabetic retinopathy can develop silently until damage is advanced. Poor vision can lead to falls, car accidents, and difficulty managing medications, all of which are major threats to independence in older adults. Cataracts cloud the eye's lens, blurring vision and dulling colors. They are extremely common. By age 80, more than half of people either have cataracts or have had surgery for them. Glaucoma damages the optic nerve, often without symptoms until peripheral vision is lost. Untreated, it can lead to irreversible blindness. Macular degeneration affects central vision, making it hard to read, recognize faces, or see details. Diabetic retinopathy causes vision loss from damaged retinal blood vessels and is a leading cause of blindness in older adults with diabetes. Most vision loss from these conditions is preventable or treatable when caught early. That's why experts recommend a comprehensive dilated eye exam every 1 to 2 years after age 65, more often if you have diabetes, a family history of eye disease, or existing vision problems. Unlike a quick vision chart test, a dilated exam allows the eye doctor to see the retina, optic nerve, and blood vessels in detail. Why hearing screening matters after 70. Hearing loss affects more than 2/3 of adults over 70. Yet many people ignore or deny it for years, assuming it's just a normal part of aging. The consequences go far beyond missing words in conversation. Untreated hearing loss is strongly linked to cognitive decline and dementia, likely because it increases the brain's cognitive load and reduces social engagement. It's also a major contributor to falls. The brain uses subtle auditory cues to help maintain balance. Screening for hearing loss can be quick and painless. An audiogram performed by an audiologist is the gold standard, measuring hearing ability across multiple frequencies. Even a simple in-office hearing check or validated smartphone app can flag potential problems. If hearing loss is detected, options include modern hearing aids, now more discreet and effective than ever, assistive listening devices, or in some cases medical or surgical treatments. Research shows that treating hearing loss early can improve communication, restore social engagement, reduce depressive symptoms, and help preserve cognitive function. In one landmark study, older adults who started using hearing aids had a nearly 50% slower rate of cognitive decline over 3 years compared to those who left hearing loss unaddressed. And now, I'd love to hear from you. Where are you watching from? Have you ever declined a test your doctor recommended, or chosen one that truly made a difference? Share your experiences in the comments. You might help someone else make a smarter, safer choice for their own health.